So we'll continue with ECG. A normal P wave, the duration, it is 120 millisecond, that is around 3 small square. So we'll try to understand the changes that we see in P wave. So we have a condition called as P mitral, also called as a bifid P wave, also called as a M-shaped pattern. This P mitral is seen in a condition called as mitral stenosis. So you can see in the image you have a M-shaped P wave, a bifid type of P wave called as P mitral. So now we all know that the mitral valve, it is present between the left atrium and left ventricle. You can see the mitral valve present between the left atrium and left ventricle. In a condition of mitral stenosis, the left atrium will not be able to push blood into the left ventricle, and because the left atrium is not being able to push blood into left ventricle, you will see a left atrial hypertrophy in mitral stenosis. So normally the P wave that is formed, this we get due to the electrical activity in both right and left atrium, which occurs simultaneously. So when the electrical activity occurs in both right and left atrium simultaneously, we get the normal P wave. But now, due to left atrial hypertrophy in mitral stenosis, the right atrium depolarization, it occurs, or it will occur first, and then the left atrium will depolarize. And why does the left atrium depolarize late? Because there is a hypertrophy. Hypertrophy, that means increased muscle mass. There is a more muscle present in the left atrium because of hypertrophy. That is why it will take more time. So because the left atrium is lagging behind and taking more time, that is why we get the formation of a M-shaped P wave in mitral stenosis called as a P mitral. Then we have another condition called as the P pulmonale. It is the increase in vertical height of P wave. When the vertical height increases by more than 2.5 mm in limb leads. So this is important, that we can call it as P pulmonale when there is an increase in vertical height of more than 2.5 mm in the limb leads. And this P pulmonale is seen in a condition called as pulmonary artery hypertension causing a right atrial overload. So you can see in the image here you have the P pulmonale where there is an increase in 2.5 mm vertical height of the P wave. So P pulmonale is occurring because of the pulmonary artery hypertension causing a right atrial overload, whereas P mitral was occurring because of the left atrial involvement. There is a concept called as pseudo P pulmonale What is pseudo-P-pulmonale? It is the vertical height of P wave is more than 2.5 mm, but the cause is not pulmonary artery hypertension. So when the cause of this P pulmonale is not pulmonary artery hypertension and the cause is due to a condition called as hypokalemia, then the condition is called as pseudo P pulmonale. But if it is because of a pulmonary artery hypertension, it is called a P pulmonale. You have to understand that the P wave is absent in few conditions. One of that is hyperkalemia, and another one, important one, is atrial fibrillation. So we'll understand now atrial fibrillation. In atrial fibrillation you have a absent P wave and you have a increasing and decreasing variation of the heart rate. So what is the meaning of increasing and decreasing variation of heart rate? That means the heart rate is not stable. So if you see in this ECG, there are 2.5 large square between RR interval, then here it is almost 1.5 of almost 2 large square between RR interval. So it is a variable increasing and decreasing heart rate along with absent P wave. And another point that should be present to diagnose atrial fibrillation, that means along with the above 2 points there should also be presence of QRS complex. So in the ECG if you see that there is a absent P wave, a variable heart rate and QRS complex is present, then you can think of atrial fibrillation. For a patient suffering from atrial fibrillation, if you examine the pulse, it is called as irregular pulse. So basically atrial fibrillation is what? It is a disorganized, as you can see by the heart rate, it is rapid, irregular atrial activation with loss of atrial contraction and irregular ventricular rate, which is determined by the AV nodal conduction. So because in atrial fibrillation SA node is not functioning properly, so the AV nodal conduction is determining this irregular ventricular rate, and the above ECG findings are important. So what occurs in atrial fibrillation is that due to this type of atrial twitching that you see, there are clot formation present in the left atrial appendage, and this clot can go to the brain and cause a stroke, or it can go via mesenteric artery and can cause an infarction of the bowel and cause a lower GI bleed, and this will cause excessive abdomen pain and can complicate into gangrene of abdomen. or the gangrene of intestine. So why I'm mentioning this is that if you see any abdominal related symptom in a question of atrial fibrillation, think about this complication. Another one line MCQ, that atrial fibrillation is the most common sustained arrhythmia that is present. There are few predisposing factors that can lead to a patient having atrial fibrillation. One is hyperthyroidism. Another one is acute alcohol intoxication, hypertension, diabetes mellitus, and sleep apnea. So all these conditions can predispose a person having atrial fibrillation. So now we'll talk about hyperkalemia. Hyperkalemia, you see tall tented T wave, that is, the T wave is more than 10 mm in chest leads and more than 5 mm in the limb leads. So more than 10 mm in chest leads and more than 5 mm in limb leads, that should be present to call it tall tented T wave. So in these patients, as the potassium value it increases, you also will see a ST elevation. So ST elevation is seen in hyperkalemia as it progresses. Potassium, it usually causes a bradycardia. And why? Because it is basically slowing down repolarization, slows down it. As it progresses, the amplitude of P wave that will reduce, and gradually the P wave then will disappear. So you get a tall T wave, you get ST elevation, the P wave will disappear, go down, and because the heart is slowing down, the PR interval also increases, the QRS will become broad. So basically when you think of hyperkalemia, just think tall tented T waves, increased PR interval, QRS is broad, but P wave is disappearing, it is becoming small. As the QRS it becomes broad, the QRS will eventually then merge with T wave. QRS it merges with T wave, and then there is a formation of sine wave pattern. So in hyperkalemia we see a sine wave pattern. Sine wave pattern is like this. The ECG will look like this, sine wave pattern seen in hyperkalemia, and this is then followed by asystole. So obviously I'm talking of a patient who is not treated. We'll go to this direction, will follow by asystole, and then eventually will lead to death. So this was all about hyperkalemia. If you get an MCQ easily, you will be able to pick up. Now we'll go towards hypokalemia. So if you understood hyperkalemia and you remember hyperkalemia, then easily you will tell what is hypokalemia. The T wave amplitude is reduced, or you also see a T wave inversion as you are seeing on your screen. That will lead to an ST depression, very easy to remember. P wave height, it is increasing, and as we discussed in the previous slide, this is called as the pseudo P pulmonale. So in absence of pulmonary artery hypertension, you get a pseudo P pulmonale. And one thing I told you in the initial part, that U wave, we spoke about something that is a U wave. U wave is present normally also, physiologically also you see, but in a hypokalemia patient you'll have prominent U wave. So just remember this point for just an MCQ purpose. But what is important in hypokalemia MCQs are this, T wave inversion. And if a high level MCQ comes, then they'll ask you prominent U wave as well, which is seen in hypokalemia. Thank you and do revise.